Hi guys, and welcome back. If you're serious about a career in medicine and dentistry, right, you know it's not always about finding a cure. It's not always about treating people, in an ideal setting. Sometimes it's about making incredibly tough but compassionate decisions. Today we're discussing a very important concept in the NHS, in the ethics of how it deploys medicine, if you like, and that is ceilings of care. This idea is particularly relevant in areas like intensive care and palliative care, and of course then your ability to discuss it potentially well, potentially well, so that it does set you apart in the interview process. Simply defined, ceiling of care is the predetermined maximum level of medical intervention a patient will receive in the event their health rapidly declines. It's not about withdrawing care. It's about setting a sensible limit on treatment escalation. It ensures we don't put a patient through aggressive, painful, or undignifying procedures that are likely to cause more harm than good. It's what doctors call futile treatment. If you want some context to it, read up about the Charlie Gard case. Think of it like this. Instead of generic of do everything, the healthcare team, the patient and the family, they collaborate and they decide and answer the question, how far do we go here? You can think about a few categories, I guess, here, and I feel this will be useful for you to look at individualized situations and be able to discuss them in broadly three categories, I think. One is full escalation, i.e. the patient will be offered all available treatment and intervention, including transfer to intensive care for invasive mechanical ventilation if needed. The other one is perhaps ward-based care, i.e. the patient will receive aggressive treatment, but on a general ward, like strong antibiotics, fluids, non-invasive breathing support, but they won't be transferred to highly intensive facilities like the ICU, intensive care units. The third category, of course, is palliative care only, i.e. the focus shifts entirely to comfort and symptom management, like pain and nausea. So no aggressive treatment will be pursued, and the priority is quality of life, not about prolonging life at all costs. So when we think about ceilings of care, what are the ethical considerations that we need to think and stitch together? I think the first one here is do no harm, i.e. non-maleficence. The core principle being that it is to avoid causing more harm. For the frail, elderly patient with multiple severe illnesses, forcing them through highly invasive procedures like ventilation might only prolong their suffering with minimal chance of recovery. And so setting a ceiling of care is important, and it prevents a burdensome form of treatment. I hope that makes sense. The other pillar that you might want to think about is autonomy, i.e. respecting one's choice. If a patient has capacity, they can understand, they can retain, they can weigh up. Their wishes are paramount. The ceilings of care needs to incorporate that decision and must respect the patient's right to refuse any treatment, including life-prolonging treatments. This is often documented through advanced care planning and using forms in the UK like the RESPECT form, i.e. recommended summary plan for emergency care and treatment. The third issue to think about is, of course, best interest. If a patient lacks capacity to make the decision, the medical team, i.e. you and me, we must act in their best interest as defined by the Mental Capacity Act of 2005. This means considering what the patient would have wanted, their values, their quality of life, guided by the input from family and relevant carers and advocates. But of course, you're looking at the best interest. As a future clinician, you need to understand that setting a ceiling of care is not giving up on them, is not giving up on the patient. It's an active, it's a compassionate decision-making process. Communication is key. These decisions require difficult, honest conversations with patients and families. You need to use empathy and clear, non-jargon, understandable language. You need to be able to talk about the patient's prognosis, i.e. their likely outcome, and what life might look like after aggressive treatment. There's an importance of teamwork here, i.e. ceilings of care are decided by an MDT, i.e. multidisciplinary team, doctors, nurses, specialists, and often palliative care team members, so that we ensure holistic and balanced view. If and when you are asked about this in interviews, and I'm sure you will because it's such a big area, show that you understand the goals, i.e. balancing the medical possibilities of treatment with the human experience of the patient. It's all about ensuring that care, even at the end of life, is always focused on dignity and quality. I hope you found this explanation helpful. If you have, then come back, like, subscribe, come to our website, look at all the articles, learn, and really go and do well in your careers, in your interviews. Thank you very much.